Well, hello everyone, and welcome to Let's Talk SADS Live Canada. Here we are on our final episode of the year on the 12th of the 12th, and I am your host, Dr. Shu Sanitani. Delighted to be coming to you from Vancouver today, and very privileged to be part of this series. It's hard to believe it's been almost a year, and no one has pulled the plug on me yet. But it's still early days for that. Um, Really enjoying these series, and today will be no exception. This is a place where we come together and we learn from each other. We're learning together. Lots of curiosity about SADS conditions, sudden arrhythmic deaths, and their causes. We've talked to a lot of interesting guests this year, and it really has been a lot of learning for me. Um, some of you will know, of course, if you've been tuning in, that I decided that we would do a fun Canadian fact, or maybe not so fun, but an interesting Canadian fact. A lot of them turned out to be historically important events, like the Canadians winning the Nobel Prize for diabetes research, the Hospital Insurance Act, which talked about access to healthcare, and of course, the person who started the crash cart concept, Dr. Fred Wilson. And then we talked last month about arrhythmogenic cardiomyopathy, including the Newfoundland variant. So we've had lots of these Canadian facts, and so we thought we'd wrap up the year with our SADS Canada Trivia Challenge. And so Evan Kruger, who's our amazing production manager and does everything behind the scenes, has put together a great contest with a prize. And so one submission per person, and you've got to answer 3 out of the 5 questions right, and then we'll put your name in a draw for $200. And so there's five questions. So, and here's an example of the question. Who was our guest when we learned about George Mines? That was our first trivia fact. And so you obviously, it helps if you've watched the episodes. These are not necessarily things that you can guess easily. So, and they're available on the SADS website. You can link to the previous episodes. And so just on this next slide here, there's a QR code, and we're going to continue to promote this. Sorry, the slide's a little messed up there, but yeah, so scan the QR code and play the trivia game. And then next year, we're going to do something a little different, and more to come on that next year. But it's been very fun for me to research these interesting facts. Now, our guest today is a dear friend of mine, someone I've known in the SADS realm for over 25 years, and really needs no introduction. But Susan Etheridge, shown here in a variety of scenarios, she really is an international phenom. So does lots of traveling. I think some pictures there of her in Ghana, and in the bottom left there, she spoke here in Vancouver recently at a scientific conference we organized. Now, she is a pediatric electrophysiologist and a SADS expert. She's actually the vice president of the board of the American SADS Foundation, a huge supporter of our activities up here, and really a partner in everything we do. Also, important roles in advocacy with American Heart Association, and has been the program director in Salt Lake City at Primary Children's for the past decade, I want to say. So let's bring Dr. Susan Etheridge into the studio and ask her some really great questions. And we're going to talk about long QT syndrome today. So long QT syndrome, and Susan Etheridge is what such a great way to finish the year. So Susan, thank you so much for joining.
Thank you for having me. I'm very excited to be here and for showing those wonderful pictures where I was either far away or a lot younger. So thank you.
The the photos I have are those were the only ones I could show. So now Susan has kindly joined us, and I'll apologize right off the front. It's impossible for me to call her Dr. Etheridge. Uh, she is like family in our house and has hosted my daughter and my niece for dinners when they've been on their educational journeys in Salt Lake. Um, and Susan is kindly coming to us from Alaska, and I have to get her to just pan up a little bit to show us those things that are in the background there. So, so Susan, tell us a bit because it looks like you're in a knight's museum or some sort of jousting gallery.
So I'm in their exercise lab, which is been decorated to feel like you are in Arthurian England. So there's a castle on one wall you can't see, and then the other stuff behind me. So this is the exercise lab in my clinic in Anchorage.
Wow, and you've done outreach there for a long time, so
About a decade, yeah.
that is great. So let's let's take a bit of a walk down memory lane and let tell us a bit about how did you become one of the leading experts in SADS conditions. Take us back. So at some point you were in college or medical school. um
And then
how did you
residency and then
yeah
fellowship. And in fact, the whole idea of long QT syndrome was known, but not really well known until I was actually a fellow or even beyond. So I graduated fellowship in Minneapolis and then joined the group in Salt Lake City, Utah. And was asked by Dr. Mike Vincent, who started the SADS Foundation in the US. I was asked to be part of the board with him. And really, through his great experience in taking care of the children of many of the adults that he took care of, I learned about long QT syndrome. So I really do have to just credit Mike Vincent for everything that happened. I didn't know this is what I wanted to do. I had no experience in it because it didn't really exist as an entity when I was a fellow. So I learned everything kind of from the beginning. Um, Utah has a long history of long QT syndrome research, both clinical research and basic science research. And in fact, Evan, if you show the slide, I can show you some of the historical data. So on the bottom in the colored picture, in the red tie is Dr. Michael Vincent. Next to him is Dr. Mark Keating, and next to Mark is Catherine Timothy. So Mark was the man who, along with Michael and Catherine's clinical input, identified that long QT syndrome was genetic and was inherited, and really found long QT1. And then later, his lab at the University of Utah went on to characterize long QT2 and 3. And then Catherine Timothy really pushed hard to try to figure out this other group of long QT patients who were quite ill, but also had other non-cardiac features, which has subsequently been named in her honor, Timothy syndrome. So I feel incredibly lucky to have worked with these people, and some of the original patients in these large pedigrees were in fact my patients, where we submitted blood and genetic data were then identified. This is a picture of Michael when he was quite young in black and white, looking at the pedigree of the first long QT family, which is a large Utah family with long QT type 1. So,
and what a great photo. There's so much history, so much captured in there. And if you look closely, um, uh, just to to next to his arm is what looks to be a calculator, one of those old calculators that all of us used to have to carry around. No one had smartphones or things, and so we were constantly looking for the calculator in the clinic. So you needed calipers, of course, which are the pointy things that we use to measure the QT interval, and then the calculator to do the math. And that looks like a very large family pedigree, generations and generations. And of course, Utah has some of those families that are, well suited for genetic discovery, where there's, a lot of relatives who are, distantly connected but may have the same condition, and that really adds to the, the credibility of the findings. So, and Catherine Timothy is, I've had the privilege of interacting with her, and to be, to be honored with the, the naming of, as you say, unfortunately, a very lethal form of long QT syndrome, is an honor nonetheless. So, now, in your practice, you probably look after mostly children, but do you also look after adults at your facility?
I do often keep the adults at least into their late 30s and 40s when they start to develop adult type heart disease, and that overlap is probably something better matched or managed by the adult cardiologist. But I'll keep them while they're younger patients. It's kind of nice to see the whole family, and gives you a really different perspective. Sometimes I'll be in clinic with 3 generations of long QT patients, because the grandparents will come, one of the parents will have it, and 3 of the kids will have it.
Wow. Wow. And of course, for our audience, many of you have lived this or know this, that long QT syndrome is mostly an autosomal dominant. So it can be passed on from a parent to a child in 50-50 cases. And of course, people know that the math doesn't necessarily, because you have 2 children with it, doesn't mean your next child isn't going to have it. It's each time you have a child, it's again a new 50-50 chance, and so that's why it really grows. Now, our title today is really talking about insights and challenges. So, what are some of the big discoveries that you've been involved in and seen? You, of course, have written lots about long QT syndrome and have been in some of the really important papers. So, take us through a couple of your, I remember this, or this was a paradigm shift for us.
I remember when my first patient that I ever cared for with long QT syndrome type 2. So when I met her, she was maybe 6 and had an arrest in the school when she heard an alarm clock. A fire alarm. And she came to clinic with her grandma because her mom had died, and had died in the postpartum period. And I remember gathering her blood and her EKG, because we knew she had long QT syndrome because she had a QT that was quite profound, but we didn't know what type. And I remember sending that over to Mark Keating, the man I showed you in the slide, to his lab. And I remember the day we got the genetic results back. Those were days when it might be years between when you sent a research blood sample to a lab and you actually got the sample back. And hers was years, but I remember the day we got it back. And it was for her, wonderful, maybe. For the grandmother, wonderful, I think so. Because at that point, we could actually say, this is what this is. And now we can move forward and treat this with all of the information that we had at the time to do really precision medicine type treatment. And I think that having watched long QT from the beginning and watched from we were just like, oh yeah, we'll have some beta blockers, to now a much more patient-guided form of therapy has been really incredibly rewarding. And to be able to pass on any new data to the family has been rewarding. I think the things that have been really important is the number of patients that we can avoid an ICD in, because that's a difficult therapy for a child. The advances in sympathetic denervation and the ways that procedure helps patients is really important. And then the evolution of, these are the good beta blockers, Nadolol, propranolol. These are the good beta blockers, so that it isn't a beta blocker failure in patients. So that's kind of where I have found the most joy, is being able to sit with a family and say, this is what we know that's new, and actually have something new to say.
So probably in my clumsy way of asking things, you've covered an amazing amount of information. So let's trace our steps back to some of it. One of the things you mentioned is something I want to highlight here. long QT type 2. So there, long QT syndrome essentially has three main types, 1, 2, and 3, based on the times of discovery. Types 1 and 2 are potassium channel abnormalities, and type 3 is the least common of those main three and is a sodium channel. Now that doesn't, for those of you who think, oh, I have to watch my potassium or eat more salt, that's not where this is going. This is really at the cell level. But the long QT type 2, the fact that they have events, so cardiac arrest or loss of consciousness or heart rhythms with sudden startling sounds, is still something that I don't understand. And do you have secret insights into that? And I'm also curious how you manage them about avoidance of those sounds.
Yeah, I don't have any insights. I've seen some very interesting tracings in the literature where they actually provoked these events by, bringing a patient in, putting them on telemetry, and then doing a challenge essentially. And you can see their QT prolong, ectopy start to happen, and then the arrhythmia. So how I avoid them, I have, there's a couple of populations you care about. One are the children, and then one are the postpartum women. So in the children, I talk to them about telling the school to warn them when they're going to have a fire alarm. And then also having their alarm clocks not be scary, screechy sort of sounds that wake them up. So either kind music, or the parents to just go in and softly wake them up rather than, startle them awake. I have them avoid haunted houses where things jump out at you and scare you, which I hate anyway. So, and then in the postpartum period, that's a terribly difficult time for a mom. There's a lot going on, there's physiologic changes going on, but also just emotional stuff. So, I love the thing that Peter Schwartz called the hungry baby alarm clock, and that can provoke these events in the moms, and trying to engage the dad to do some of that nighttime hungry baby alarm clock work for the baby. And then just very, very, I actually increase their therapy often in the postpartum period for the first 9 months, and then back off in the beta blocker after that. But that is a particularly difficult time for these mothers. However, having said that, I haven't had any trouble in a mom where I've known she's had long QT syndrome and we've continued the beta blockers. Historically, we've had trouble where the mom didn't know she had long QT syndrome until she had a postpartum event.
Yeah, so lots of things to emphasize. Beta blockers are safe, in children and in moms and in breastfeeding moms. They're there are safe medications that have been studied for not 100 years, but getting close. And so definitely important to continue medications, especially if you're a long QT mom that is pregnant, and you should be followed in a special clinic. It's the unexpected nature of the sound that seems to be an important component. So if they know it's coming, then it doesn't seem to have that startle, and we sort of imagine that that sort of that sudden jump that you described in the haunted house, that's sort of an element where your adrenaline is just sort of wasn't expected and maybe a bit more dangerous in that context.
I do think that the awakening from sleep is maybe also a really a worrisome time. It seems like for me, like waking them up when they're already asleep and things are already, the autonomic nervous system is doing whatever it does in sleep. And then all of a sudden you add to it this loud, scary thing. So doorbells, alarm clocks, those worry us.
We definitely, our group and others have been focusing on this, what we call autonomic conflict. The same thing, Mike Ackerman has shown us the picture of the woman that's swimming. Long QT1 has a swimming specific trigger. And that's, again, probably one of these autonomic conflict where you're activating your adrenaline because you're jumping into cold water, or you're swimming and using, energy and exercising, but you're also by submerging your face, you're activating your vagus nerve, your vagal. So the sympathetic and parasympathetic, when they both are told, you're in charge, sometimes there's this autonomic conflict, which then creates arrhythmias and events. So it is exactly that. So prepare for the sound, avoid the startle, don't miss your meds. Now, long QT1 is we mentioned the swimming, and it's the, I won't say it's the easiest to manage, but it has the best response to the beta blockers. And you mentioned Nadolol and propranolol are the go-tos. So if you're out there and you're not on one of those and you have long QT, it's worth checking with your heart rhythm specialist, your SAD specialist. Long QT type 2, however, is a little bit trickier because you can have these events, these startle events. You can have events at exercise, but also at rest. So I find it tricky. Now, you're in Anchorage, and I know that your colleague and also very eminent electrophysiologist, Steve Compton. So I think you and he worked on a paper that talked about potassium supplements. Do you still give potassium supplements to your long QT type 2s?
So I will counsel them about potassium containing foods and avoiding situations where, or at least coming to attention under situations where their potassium is going to be low. Things like gastrointestinal disease, when you're vomiting, that really can lower your potassium. We would certainly avoid medications that cause potassium wasting if we can. We go through a whole list of foods that are high in potassium when we first meet these kids, but I don't give them oral potassium right at the beginning. If they start to have events on their beta blocker with good beta blocker compliance, we will add potassium. Or if their QT is just profoundly long, I might add some potassium therapy. In our study, so Steve did the original study where they gave IV potassium to people trying to drive their potassium up. And then we took that and did it orally. And it's doable, but a kidney is very smart. And it's very difficult. And just potassium alone wasn't enough. We had to give them a potassium holding on to agent like aldactone, to hold on to it. But I think just avoiding times of low potassium is really important. And I think that's also important when a patient is inpatient. That's a time we can control the potassium. And we should just, whenever your kiddo comes into the hospital and is going to undergo, surgery, it's nice to know what the potassium is and to control it into the higher normal range at that point.
Right. Yeah, no, those are good sort of additional treatments and things to be aware of. So, important to have the SAD specialists involved in some of these, upcoming procedures, elective surgeries. I was recently asked, if a patient, they needed a bowel prep for, a gastrointestinal condition. And, one doesn't necessarily think of those right away, but of course those shift your electrolytes quite significantly. So you just have to be a bit cautious around things. Now, one of the topics I love to talk about, and you and I love to talk about, is this whole concept of exercise, and not all of the long QT types are necessarily prone to exercise. So let's talk about 1, 2, and 3, individually, or 1 and 2 and 3 separately. So what kind of conversations are you having with the family? Their kid loves, flag football, is going to play in the National Flag Football League. What are your conversations like around exercise and long QT?
So I'm a fairly liberal exercise prescriber, and I also like to undertake this in a shared decision-making manner. I think that 2 decades ago, physicians were very paternalistic. They said, do this, and the patients were just supposed to. Now we kind of engage the patients and their families and even their coaches in these difficult decisions. I think once a patient is treated adequately, has proven on exercise study that they're adequately beta blocked, and they have the appropriate sports equipment available, their electrolytes, no reason that their electrolytes would be worrisome. They have an AED in either their equipment or the equipment where they're exercising. I am very liberal about what I allow. And I think that there has been a shift in the recommendations from our important societies to say that that's the way science is moving, that we are allowing people to exercise as long as they understand that there's risk and they're willing to accept that risk. And every patient's different. Some patients are very risk averse. They're like, well, I'm just not going to do it. And other patients, sports are so important to their life that they're willing to accept the small additional risk that long QT brings to the sports arena. Swimming is something I've always worried about a little bit more because it's a terrible place to faint. Having said that, I have allowed long QT patients, even long QT ones, to swim with precautions. Like their coach needs to be okay with it. Everybody needs to watch them while they're in the pool. There needs to be a towel and an AED available. But I'm much more liberal than I used to be about allowing sports, and I am probably more liberal than many people, although I think that the SADS community and the pediatric electrophysiology community is really moving into allowing these sports activities. It's a much harder thing for us to do. We have to have long discussions about why sports cause trouble. We have to have long discussions with the families about the science behind long QT syndrome. It's way easier just to say, no, you can't play sports. But that's not necessarily fair and not necessarily right, because sports bring a lot of really important things to the lives of these kids. And I think that psychologically and developmentally, I think that they're really important. So it's a long discussion with every patient, and it's a different discussion with every patient.
Yeah, and I'll push back a little. I'll be a terrible host. Even the concept of allow or disallow is something that we're moving away from, and so we really frame the conversation as here we're quite pro exercise, and we say you can do whatever you want or whatever your parents are going to let you do. You just tell me what your safety plan is. And if your safety plan is going to pass muster, then go for it. So, I always use skydiving as the example, or, open water swimming. Say, okay, so you want to swim, across a lake? That's fine. What happens in the middle of the lake if you are suddenly symptomatic and you need to stop? Well, then, there's a boat right next to you and you're pulled out, and there's an AED in the boat. So it can be done, but exactly as you say, it takes these conversations and time and really thoughtful sort of planning on the part of the family. Sometimes you have to bring the coaches in so they're not freaking out, because I agree, it's way easier to disqualify someone and just have them sit out. That used to be, you and I probably had the same experience in phys ed class and in gym class. If you came and you had anything, they would just say, well, go sit over there and read a book. So it was that was the default, is if you're a troublemaker, then go sit out. So I agree. And I think we're going to see some exciting data from of course Rachel Lampert and Mike Ackerman as the investigations. They've just recently published hypertrophic cardiomyopathy, and found that vigorous exercise was no different from those who didn't do vigorous exercise. So and a real shout out to Mike Ackerman, because he has been driving the data on this for a long time. So that
absolutely. Article, Long QT version of that should come out very soon. We've sent it back. It has the corrections. So she presented it, and it's just like hypertrophic cardiomyopathy. It's just, we can let them play.
Yeah, no, fantastic. Now, what about long QT3? This one's it's a bit of a head scratcher. So just to review, so long QT type 3 is the sodium channel. It's the least common of the common forms. The ECG looks a little bit different. And it, the genetic basis of it is just a little bit more complex, because it spills into other conditions, Brugada syndrome or cardiomyopathy and stuff. So they're just, sort of an asterisk in that they're not the typical long QT. Do you exercise restricted. And the reason I ask this question, of course, is their events don't happen with exercise typically. Most of their, their events are at rest and that. So what, do you have a different conversation with them?
Yes, somewhat. Now, nobody has as many of them, so you have maybe a handful of long QT3s where I may see dozens and dozens of types 1 and 2. Yes, I have a different conversation with them, and but I still exercise them routinely to make sure that they are adequately beta blocked, because despite it doesn't even seem to make sense since their events occur with slow heart rates, but beta blockers have proven to be at least not harmful and in some protective. So I will run them to make sure they're adequately beta blocked. And there are other forms of therapy for long QT3, different medications that actually can work and shorten their QT intervals. Their events are much less predictable. They typically occur during times of slow heart rate, so sleep. And so for me, one of the investigative things I do is actually put Holters on them or monitors to watch what they're doing at nighttime or with sleep when their heart rates are quite slow. But I do the same. I still let them play and probably feel even a little bit better about them. They're a complicated group, though.
Yeah, no, absolutely. And we are a bit limited because of the relative infrequency in our practices. So now two therapies that you've alluded to: cardiac denervation and defibrillators. Let's talk about denervation first. So as you said, that's where you either a surgeon or a cardiologist changes how the nerves go to your heart. Have you used that therapy? What are your opinions about it, or what are your triggers for going to that next level of changing how the heart is innervated?
So I have done that I typically do it more in type 1, and then some of the rarer forms like Timothy syndrome, if they have events beyond their beta blocker therapy. So for me, if you have an event of fainting or, God forbid, cardiac arrest, aborted cardiac arrest on beta blocker therapy with good compliance, and you have type 1, I will send you for a denervation. I have also sent type 1s for denervation who don't tolerate their beta blockers or are a little bit unreliable in taking their beta blockers. I think it acts as a safety net. We still send most of ours to the Mayo Clinic, where I think they have the largest experience. It's a very well-tolerated procedure. They, are in the hospital a couple of days. I haven't had anybody have lasting complications other than the half of your face gets red with exercise and the other half doesn't. And then the slightly different temperature of their hands, which doesn't really matter that much. I have sent the more complicated patients where either you didn't have a genetic diagnosis, so you're really grasping for straws, or Timothy syndrome. I've sent those kids for denervation. And then there's the very rare long QT that has 2 variants, and they have Jervell-Lang-Nielsen. They're quite symptomatic usually, and I usually add that to a number of other therapies for that really complicated patient group.
Yeah, thanks. That was important. Such an important paper that came out again about probably 27 years ago now or something. That described that Jervell-Lang-Nielsen, what used to be thought of as the autosomal recessive type of long QT, is basically 2 hits. So you get typically one from mom, one from dad, and you have a double genetic dose, and you have a worse form. So yeah, denervation, definitely, I think the side effects are those sort of unusual ones: changes in sensations and temperature. And I don't think I think all of us, and I was having this conversation the other day with a student, I think, especially now with genetic testing identifying a lot of people with long QT syndrome. So it's not anymore where one has a cardiac event and that's how the family comes to attention. That's the minority. What is now happening is that, you have a relative who has long QT syndrome, you get the genetic testing, and suddenly you have this label, and you may or may not have an abnormal QT interval. And so, you know, not all of those necessarily have high risk, but most of us are going to put those patients on a beta blocker, unless they have a very, very normal QT. And so that conversation saying, here's a condition that you didn't know you had that doesn't even really show up, and we want you to take a medication every day. So it's a bit of a tricky conversation. Now, let's get your thoughts on that hypothetical scenario. So you have a genotype positive, so they have the family variant, this 5 other people have it, and you have a child who has a totally normal ECG and exercise test. Do you put them on beta blocker, or do you just tell them to avoid triggers and be cautious?
I use what they and the family think is important. And some of those people want to be on a beta blocker, and they want their kids to be on a beta blocker. But I'm less paternalistic than I used to be about everybody in that situation needs a beta blocker. I'm not sure everybody does. And in some people, the risk of the beta blocker might outweigh the benefit. I don't think we know exactly or can predict exactly, but typically if you're a phenotype negative, your QT is normal and persists at being normal, and your exercise is normal, and you have type probably 1, maybe even type 2, you may not require beta blocker, but you still require coming back to the doctor. And I'm very, very, I make sure everybody has that Credible Meds app on their phone so that they can avoid the medications that we know cause trouble. And there are some people that never have events except when exposed to those situations where they get that medicine. And I think it's important as patients, you may know way more than many of the physicians you run into about long QT syndrome. And so you need to be proactive. And I think that having that app on your phone and being able to use it, I show them how to download it, and then I show them how to use it, is a really important part of your care or your kids' care.
Yeah, no, thanks for mentioning that app. It is free. One does have to register to use it, but it is these medications. So again, there's all kinds of medications that can have an effect on these ion channels, these potassium channels mostly, and then prolong your QT interval. You may or may not have a genetic factor also contributing. So certainly our patients with long QT are told, be careful about what the doctor prescribes to treat your ear infection, because there's certain medications that are going to make your QT interval even longer and put you at risk. In general, the longer your QT interval is, the more at risk you are for an arrhythmia or an event. So yeah, crediblemeds.org, and that's an important app. And a reminder, I wonder if Evan has a link to that on our website, but he'll be all over that. Now, defibrillators. Do you have a lot of patients with long QT who have needed defibrillators? What are your you mentioned, they're having breakthrough, they're on a beta blocker, you may or may not do denervation.
I think type 1, I have very few type 1 patients who have an ICD or require one. It's rare. It's not at 0, but it's rare. Type 2 is much more problematic. I think that that's a population that isn't as well covered by beta blocker therapy. And, I have more type 2s that have required ICD therapy, either because we've documented arrhythmias, or they've had an aborted sudden death, or they continue to have syncope despite beta blocker therapy. Type 3s, I had a number of type 3s, and in the old days, we would actually put devices in all type 3s or many type 3s once they got to a certain age. And interestingly, they did decrease the number of events that they were having, but probably because of the pacing capability of a device to keep their heart rate very regular at nighttime. So I do have some type 3s with ICDs. I think this knee jerk, you get the diagnosis of long QT and you get an ICD. I hope that's something that's in the rearview mirror for us. But that was how things were practiced in the 90s. But it's been a very long time since I've put or had an ICD put in a patient with long QT syndrome.
Yeah, that that's our experience as well, and I think certainly it's not most patients with long QT don't need ICDs. We recently, we made a very conscious choice to use a pacemaker as opposed to an ICD, just because the ICD does have the risk of giving a shock when it may or may not be needed, and so there's a little bit of simplicity in what used to be a much more used treatment, using pacemakers, and especially these long QT type 3 patients. So yeah. Now we'll just sneak a little peek ahead. Are you seeing new treatments around the corner? I know, again, there's more and more buzz about gene therapy or targeted molecules and stuff. Are you involved in any of that?
Sort of peripherally. I've been contacted by different companies that are interested, and it's fascinating to me that big companies are actually interested in these orphan diseases. It's quite a surprise. But yes, through the SADS Foundation, we have identified a number of, and I can't, for proprietary reasons, go into what those companies' names are, but I think in the horizon, there is going to be much more gene-directed therapy, like a maybe one and done therapy, as opposed to taking a beta blocker twice a day or once a day for the rest of your life. So I think hold tight for the next maybe 5 to 10 years. I think that we will see breakthroughs. There are breakthroughs on the horizon. Obviously, they're going to start with adult patients, and they're going to start with patients with more common diseases, types 1 and 2, and they're going to start with people with defibrillators, just because they have that safety net. But then once it's proved safe in that population, it'll be much more generally applicable. So I think it's very exciting and very unexpected from my standpoint.
Yeah, and families, especially the situation where you diagnose a newborn with long QT, and the parents, of course, say, is my child on a beta blocker forever, for the rest of their life? And now one really starts to say, well, probably during my active practice, yes, but 10 years from now, we don't know. I mean, the bar is very high, especially long QT type 1, where the beta blockers are so good.
Right.
And you mentioned the word compliance, that is absolutely the key. So it's, especially you have to take them regularly, you have to be on the right one, the right dose, and don't be skipping doses. Then long QT type 1, that's going to be hard to improve upon, but there will be a simplicity there. Again, there may be a once a year injection, or who knows what exactly it's going to look like when it comes to us. So Susan, we're at time now. This is, for me, it's a very wonderful way to finish our year of these webcasts, with a dear friend who is one of the lead pediatric SAD specialists in the world, that everybody sends cases to. And I'll just in closing, I'll share an anecdote. I was at a conference in Washington, the World Congress of Pediatric Cardiology, and one of our colleagues, texted me, and he's can we talk? Can I send you some tracings and stuff? It was a case, and I said, yeah, no, this is great, and I said, I'm here with Susan Etheridge. And he said, oh yeah, no, I tried to reach her first, but she didn't pick up. So, absolutely wonderful to have you, and happy holidays and safe travels in Anchorage. And we will look forward to our next gathering.
Thank you very much. It was lovely.
Well, that, as I say, that's a really nice way for me to wrap up the year and slowly start thinking about the holiday slowdown. Now, we do want you to, maybe watch some old episodes so you can participate in the trivia challenge. There was another thing I meant to mention, while Dr. Etheridge was on, the Hearts and Rhythm organization, Dr. Joe Atala, whom we must have as a guest next year. Joe Atala has been working hard with the Hearts and Rhythm group to organize access to cardiac denervation in Canada, and so that's an important development, because that's it's an uncommon procedure, but needs to be done by people with expertise. So um, really looking forward to another year of Let's Talk Live SADS. And we have our guest for January already in the backstage, and I'm very excited to be hosting that person. Also, another world-renowned SAD specialist. But for now, I'm just going to wish everybody a safe and peaceful holiday time, and I look forward to seeing you in the new